Hello, I'm Matthias Goertz, and I'm going to share with you my November update on COVID-19, following up on a similar video I posted about 1 month ago on YouTube. So I will share my screen with you. Okay. So I've called this session Global Winter. And as before, I'd like to start with a brief meditation, just a simple breathing meditation. So I'm just inviting you to make yourself comfortable on your chair. Close your eyes and just focus your attention on your breathing. Breathing in and breathing out. And relax. And open your eyes. So welcome. I will start time by sharing our tracking of the COVID-19 scenarios, which we developed in March. You may recall we framed these scenarios on the basis of two major uncertainties. One, what is the severity of COVID-19 going to be? Is it going to be moderate or is it going to be high? And second, what is the effectiveness of the global response expected to be or going to be? Is it effective or ineffective? And by using these two uncertainties as axes, we framed 4 scenarios I outlined to you last time. And as you will remember, we have since April been tracking the world against these scenarios and found that we've continuously been moving, if you like, deeper and deeper into what we call the fractured world. So we are now deep in a world in which the severity of COVID-19 has turned out to be rather moderate, yet the global response has turned out to be rather ineffective. I will share again with you some of my updates on why are we saying that this is where we are now. And then in the second part of the session, I will then move on and talk a bit more about the current situation and some thoughts about how can we start being more effective in our global response so as to not remain in the fractured world forever, but hopefully begin moving up north towards an early spring kind of scenario. So why are we saying that the severity of COVID-19 is trending towards moderate? You will recall that our estimate for the infection fatality rate, IFR, ranges, for the global IFR, I should say, ranges between 0.1 and 0.2%, meaning out of every 1,000 human beings infected with SARS-CoV-2, 1 or 2 die, between 1 and 2 die. And I told you that that's in a similar range as the pandemic influenza, meaning influenza strain that is novel to us, just as this SARS-CoV-2 is currently still novel to most of us. I also added that you need to be mindful when you look at this global IFR that there are significant regional differences and of course also national differences and even local differences. And those are primarily driven by demographics. So countries and regions with a younger population, younger median population, and especially most importantly, with a small proportion of people above roughly 60 or 65, will have a much lower IFR than regions with a highly aging population. So, for example, our estimates here that you can see are an IFR of probably well below 0.1% in Africa, which has a median age of less than 20 years, but going up to something like 0.4% in geographies such as Europe and Japan, where the median age is 45 or even higher. And you can also see that not only are fatalities highly correlated with age, especially once you're sort of beyond the 60 or 65-year-old age bracket, and that women are significantly less affected at the same age bracket as are men, which, as I said before, just really reflects the fact that women on average, depending on which geography you're in, getting between 5 and 10 years older than men, and therefore the immune system probably is, so to speak, 5 to 10 years younger at comparable age brackets compared to the men, and therefore the immune system is just better, at the same age, it's better able to handle this virus than the immune system of the average man. So the gender and the age are basically the most important drivers of what is your specific IFR going to be. Of course, it's always just a calculated number and cannot be known exactly for each individual or even for each group of individuals. But these are reasonable estimates. So the IFR is between 0.1 and 0.2%. Secondly, last time already I pointed out that the prevalence of the actual disease, COVID-19, is probably about 1% or less among all those who get infected. So 1% or less of all infected people actually fall significantly ill. All the others either have no symptoms or mild symptoms. Mild symptoms usually being of the type that is familiar from any kind of common cold or maybe a light flu. So 1% or less of all infected people become sick. And that was fortified in October. I got some new data from the US CDC, and that data sort of reconfirmed that we are roughly in the right ballpark. Third slide, which I've added since last time, I claimed last time that not only is this virus now endemic to humanity, meaning it will not go away, but also it will ultimately infect 100% of us, with very few exceptions. So I made that claim and didn't substantiate that any further. I made that claim basically on the basis of an analogy, claiming, and this is a hypothesis if you want, claiming the hypothesis that this SARS-CoV-2 is just another common cold coronavirus, of which we previously had 4 circulating endemically among humanity. And now, since early this year, or late last year, we have 5. And I was saying that's the only thing that actually happened in the last 12 or 15 months, is that instead of 4 common cold coronaviruses, we now have 5. We also have about 200 rhino common cold viruses and all sorts of other viruses. So that's just to put it into perspective. We've just acquired 1 more virus. But the reason I said it will eventually reach all of us is by analogy with other common cold viruses, because we basically all get, pretty much all of them, with probably some regional variations and so on. But pretty much all of us get all these viruses and we live with them. And from all we can see at the moment, from all I can see at this moment, this is probably going to happen with this virus as well. So I'm offering this chart here just to, it's not a proof of my hypothesis, but it it does not contradict it either, because what it shows is that we are steadily moving towards that 100% penetration. So this is a chart of global, the proportion of the global population that has been infected. As you recall, I'm excluding China because there's no reliable data, and China is so big in terms of population that it would skew my model too much. If I try to make a wild guess about the situation in China and then include it in my model, then the whole model would be doubtful. I mean, the model is anyways always doubtful, but then it would be even a lot more doubtful. So I prefer to exclude China and just say, I just don't know what's the situation in China. So when I say, as of 1st of November, 34% of the global population has been infected with SARS-CoV-2, then that excludes the Chinese population. So instead of 7.8 global population, 7.8 billion global population, this refers to 6.4 billion people, which is all those except those who live in China. Of those 34%, so 1/3 of all humanity, excluding China, by now has been infected with this virus. So as you can see, we are fairly rapidly trending towards that 100%. That doesn't prove that we will ever reach 100%, of course. At any time, the curve could flatten, right? But it is consistent with my hypothesis that we will eventually reach 100%. What you see on the chart, the yellow stars are all like individual data points from individual locations where we actually have some real data based on antibodies. So the green curve is our model curve. It's just a model curve based on data from about 10 or 12 countries where we have actual decent data, and then extrapolated to the rest of the world, minus China. There's a bit of a kink in the green line between August and September. That's not because anything happened with the virus. It's not that the virus all of a sudden accelerated during that period. That's just an effect of our modeling assumptions. In September, or in August rather, we received some new data, especially on India, suggesting that viral penetration or infection levels in India were significantly higher than we had anticipated. And this was real data coming from government-sponsored studies. So we took that to be reliable, as reliable as it gets kind of data. And so we had to adjust our model, and you can see that the penetration, because India is so big, it's also got almost 1.4 billion people, almost as many as China. And India is included in the model because there is data available. And so you can see that in September, our number became quite a bit higher just because there was this new insight about India. Also about Iran. Iran also turned out to have already then a very high penetration. So, it lifted the whole model up a bit. And we could have then gone back to our previous assumptions in August or July and try to adjust them so that it looks like a smooth curve, but we didn't bother to do that. So the kink in the curve is just simply a shift in, there's new fresh data that suggests we're actually on a somewhat higher level than we thought, okay? But from there on, we carry that forward, and you might say, well, wouldn't we now already see sort of an uptick again because of seasonal activity this winter in the Northern Hemisphere? And the answer is not quite yet. Yes, a little bit. Yes, a little bit. But the model, as I shared last time, is based on fatalities. And remember, COVID fatalities come with about 6-week, median 6-week time lag compared to the actual infection. So someone gets infected, and the median patient who was infected and dies takes 6 weeks to death, right? So when we record death, the recorded death, COVID death, reflects an infection event that happened 6 weeks earlier. So in the model, because we are modeling fatalities, the impact that we're now starting to see of the seasonal increase in infections, especially in Europe, isn't yet very visible as of 1st of November. But certainly when I update it next time, as of 1st of December, yes, we do probably expect quite a significant uptick in this curve because of seasonality. All right. Yeah, just to add to this, US CDC has said about a month or two ago that they think in the US there's a factor of 10 times of the recorded cases versus the real cases. So 10 times as many people as are infected as are recorded to be infected. In other words, if you go on Worldometer, which is everybody's favorite tool, and you look at the recorded infections in the US, you see something like just under 10 million, to say a rough number, as of today, right? And that means that actual infections would be 100 million, right? The US has 330 million people. 100 out of 330 million is about 30%. So you see that the US is not very far away from this global average, right? So our model is consistent with that statement by the CDC. Then last month, the World Health Organization the first time came out with their own estimate. So they have a model, which I haven't seen. So I don't know how they model this. And they calculated that the actual number of infections is more than 20 times higher, globally, more than 20 times higher than the recorded number. And at that time, they said in their model, they had 760 million infected people. And at that same time, when I compared it with my model, I had about 1.8 billion. So I have about 2.5 times as many infected people in my model as does the World Health Organization. So in my view, obviously I believe in my model. I know it's iffy in many ways, but order of magnitude, I believe in my model. So I think the World Health Organization is underestimating the infections. But without having seen their modeling assumptions, I cannot comment. I just want to point out to you, I'm saying we have about 50 times, almost 50 times as many actual infected people as there are recorded infected people on Worldometer. If you take the Worldometer figures, the penetration, global penetration would be about 0.7%. I'm saying it's about 34%, so it's a factor of roughly 50. World Health Organization says the factor is roughly 20, a little bit more than 20, 22, 23 or something. Yeah, just to give you a flavor, there's still a big variation between the World Health Organization and my model, but at least the World Health Organization is starting to talk about real figures, which previously they had not really done. They kept talking about these recorded figures, which are not particularly useful. Right? Although, unfortunately, they inform most policy decisions, but actually they're not particularly useful. And the World Health Organization is now coming apparently around to recognizing that. So that's good. So you could say there's a bit of a convergence between what we are saying and what the World Organization is saying. Okay, to summarize, and I said this before, just to give you the summary, 100% of us will be infected. 1% of us will get severely ill from COVID-19. And 0.1 to 0.2% of us will die. But that probability depends a lot on our age. I'm 55, I'm male, so my probability is already significantly higher than 0.1 or 0.2%. It's probably already in the range of 1 or 2%. This, at the moment, assumes no real therapy, no real effective therapy, and no vaccine. So these are the key numbers to keep in mind, and those are the key numbers that make us say the severity of COVID-19 is moderate. For even though all of us will be infected by this virus, rather few of us actually get ill, and rather very few, it's not trivial, of course, but rather very few actually die. 0.1%, 0.2% of the world population of 7.8 billion would still imply somewhere between 7 and 15 million people might die of COVID, unless, of course, at some point the vaccines come in, etc., or the therapies come in and lower that value, right? which will probably happen. But at this current rate, that's still a significant number of deaths. So we are not trying to downplay that, yes, there are fatalities, but relative to the global population, in percentage terms, it is quite small, and it is not different from a pandemic influenza, and it is trending down. And there are good reasons to hope that it will just continue coming down. So the second axis, we said the effectiveness of the global response. We are seeing trending towards ineffective. Why are we saying that? Well, first of all, let me start with the cost of the heavy hammer that was pulled out this year by many governments. I already shared the GDP analysis with you, very simple analysis. My argument was basically a virus is no reason at all to shrink your economy. It is neither a reason to shut borders or to create national or local lockdowns, quarantines, or any of those things that have been disrupting our global economy. None of those are, in my view, necessary, and I'll keep talking about that later. Instead, a novel virus could be, a challenge that we could have risen to by investing into it. Investing in PPE, in ICU capacity, in respiration ventilators, in training of people, in masks supplied to all the people who need them. I'll talk about that later, etc., etc. And I just did a wild guess here that, well, if we had heavily invested in this, we would have grown our GDP by another 0.5% on the positive, right? So instead of the baseline 3% or so that maybe economic organizations had predicted for 2020 at the beginning of the year, we might have had 3.5% growth this year if we had wanted to. But we didn't want to. Instead, we preferred to have something like a minus 4.5% shrinkage of the GDP. Yeah. So there is a 8 percentage point gap between what it probably will turn out to be and what it could have been, and that's $7 trillion that basically our governments collectively decided they wanted to destroy, or they are destroying, right? And that's our common welfare, and that's a real cost of the hammer, which doesn't have any benefits as far as I can see. There's a lot more, of course. There's collateral damage other than the economy. In fact, the economy is arguably not the most important. There's, of course, societal, psychological. Last time I had a chart where I said there's indication that the early hammer in Europe may have increased the IFR above what would have been expected, meaning there were more deaths than would have naturally occurred because of the lockdowns. My argument was the lockdowns will have brought so much disorder into the health systems that more people will have died because of the lockdown rather than fewer. But I can't show any real empirical evidence, so that hypothesis has not really so far been supported by data, but I don't drop it. There's also a general impact on public health, which is, for example, because ICU beds were reserved for potential COVID patients who might have needed ICU treatment, other operations that should have happened during that time frame were delayed, right? And that will have cost some amount of lives, right? Which will show up in the surplus mortality. So when we look at surplus mortality in those countries that publish surplus mortality figures, not all of that surplus mortality will be people who, sort of immediately died of COVID-19 or its complications, but also people who died of some other fatal thing who didn't get the appropriate treatment in time because of COVID. So it's an indirect COVID-related death rather than a sort of direct COVID-related death. But those surely will be there. We just won't find it easy to quantify all this. Livelihoods, well, GDP, I think, tells most of that story. And then, of course, rights and freedoms that were in almost, virtually the whole world, were severely restricted over the last 6-7 months. And I'll talk about that a bit more. So I had this cartoon. I'm bringing it back. The hammering is going well. Only, I don't feel like dancing anymore. Remember, there was this early idea that we have to hammer down, and then after that we'll be dancing with the virus. But I think we are not ready. No longer fit to dance because we've hammered ourselves too much. National emergencies, border closures, curfews, suspensions of parliaments. Even now, still certain decision-making by governments, where parliaments should actually be involved, but are in military deployment, like the lockdowns, of course, quarantines, mandatory tracings, testings, and masks, discrimination. Recently a case of an island in South America that said only people who can show that they have antibodies are allowed onto that island now. So it's like a positive discrimination in favor of those who are already through the infection. And of course, the big one that is yet to come, in my view, is mandatory vaccination. I anticipate that quite a lot of governments, unfortunately, will make the choice to mandate vaccinations, either de jure, by issuing decrees that people actually must get vaccinated, like it or not, or if they deem that to be too much an intervention into the legal aspects, they will do it de facto by, for example, saying, you don't have to get vaccinated, but if you're not vaccinated, we don't let you travel, or we don't let you participate in certain events, or access certain locations, or whatnot, right? So, there are many ways to de facto force people to get the vaccination. So I worry that either de jure or de facto governments will do that. So that will be yet another severe interference in our physical integrity. And I said, all of that taken together suggests to me we are now in what's called among theorists, political theorists, a state of exception, which is defined as a sovereign's, usually a state's, ability to transcend the rule of law in the name of the public good. So governments saying, because we protect you, therefore we can undermine and suspend all these individual rights and freedoms that people normally have. That's a state, it's called a state of exception. And arguably we are now deep into this state of exception in most parts of the world, in some more than in others, but that's quite a almost universal phenomenon. If you take as an example Article 1 of the German Basic Law, which is the German Constitution, it starts with human dignity shall be inviolable. To respect and protect it shall be the duty of all state authority. And remember, this German Basic Law was written in the aftermath of the Nazi period in 1948-49. Specifically with the Nazi period in mind, the people who came together to draft this law, this basic law, said that should never happen again, because the concept of state of exception came out of the fascism and Nazism period. So this Article 1 of the German Basic Law was specifically meant to prevent these kinds of suspensions of the law to happen again. Now, we have certainly now temporarily suspended Article 1 of the German Constitution, is my argument. Constitutional judges may disagree with that, right? I'm not a judge. I'm not trying to judge. I'm trying to understand the situation. In my view, as a philosopher, as a layperson, when it comes to legal matters, we have suspended, at least temporarily, this Article 1, which is the foundation stone of the Federal Republic of Germany. And possibly, we may have suspended it permanently. And the reason I say that, and that's one of the biggest dangers with this, what we've done this year, is that governments, including in Germany, have now learned that, we can get away with it. a majority, even today, up to now, a majority of Germans consistently in surveys says we support these measures. In other words, we support the government suspending our basic rights and freedoms. So they have a majority of the population behind them. Now, a democracy is not just about doing what the majority wants. You know, a democracy, certainly the majorities matter, but a democracy is also about, you know, adhering to principles that are unshakable and have nothing to do with what the majority think. They're just basic principles. And secondly, democracy is also about protecting the minorities. So there are people who object to these measures who are not being heard. Even though the government has maybe a majority of the population on their side, that doesn't mean they're doing the right thing, right? When Hitler invaded Poland, or when Hitler passed the anti-Jewish legislation in Germany in the late or mid-1930s, he presumably also had a majority of the population behind him. I don't have I don't have survey data on that. Maybe they didn't do surveys at that time, but you can be quite sure he had a vast majority of people behind him when he passed those decisions and policies. That doesn't mean they were the right things to do, okay? And I'm quite deliberate in using this analogy, okay? I'm quite deliberate because we are in a similar situation to, you know, Germany in the 1930s now. Now, China, I mentioned last time, I'm not including China in the model because I don't have data, and the reason I don't have data is that Xi Jinping went to Wuhan in March, looked at the situation, raised his finger, and ever since there has been no single new fatality recorded or made public, recorded maybe yes, but not made public in China. So since March, for 6 months now, not a single person out of 1.4 billion people in China has been registered to have died in conjunction with COVID. And since my model is based on fatalities, therefore, obviously, I have no clue what the actual fatalities are in China. They're clearly not zero over 6 months, right? And I sort of made a joke and said, well, the gesture that Mr. Xi made in Wuhan reminded me of Neo in the Matrix, the movie. I made that sort of, that's what it reminded me, that's what I called my déjà vu. Oh yeah, you could just stop the virus in midair. But more seriously, I was thinking, well, what might he have said and what might he have had in his mind? And this is a pure conjecture on my part. I wasn't there. I didn't read anything about it in Chinese either. But, you know, I think what he probably said is, you know, the government has this evil dragon under control, but it could rear its head anytime. So we must remain on our guard and keep the discipline up, right? So he called on the population of China probably to, this is dangerous, this is scary, and you have to all be very disciplined and now go back to work. China will probably be the only major economy, if not the only economy this year that will show positive GDP growth. And that's largely because Xi Jinping went to Wuhan on 10th of March and decided, I want to see GDP growth. Right? He understood the virus better and earlier than most governments, I would argue. He understood just what we are saying, which is the virus isn't that dangerous. For most people, it's harmless, right? And he understood that probably. He looked at the situation, looked at the data, and said, oh, it's not as bad as it might have been, and it does not prevent us from growing our economy and becoming ever more powerful, which I think is sort of the agenda. But it also at the same time works very well to discipline the population and keep them suspended in a permanent state of exception, right? So he might have thought, he might not have said anything like this, but he might have thought, and I'm putting words into his mouth or thoughts into his brain, you know, he might have thought, well, we'll just not publish any real data, and occasionally we'll, you know, pick some location and clamp down just to demonstrate, the danger is still there, but we, the central government, we can control it, right? And, you know, conveniently, then he would choose locations in, you know, kind of unruly provinces like Xinjiang. I mean, we saw, I think, in Urumqi lockdown, and more recently, I think in Kashgar, local lockdown. We also saw one in Qingdao, which is sort of a mid-sized, major but mid-sized city, important enough to be on the map in people's minds, but not important enough to really disrupt the economy. So it's not Shanghai or Beijing or Tianjin or Chongqing or the likes. So it makes a great example to go in and say, look, oh, there's a local outbreak, and we will test the entire 8 million population, just to demonstrate that we can. Right? Doesn't mean by any means that there are no other local outbreaks in other parts of China, but it's basically picking certain events to just demonstrate power and control, and in doing so keep everything suspended in a permanent state of exception. That's my argument. Yeah, so the second point we made already last time is that we are observing a divergence in policy responses. And some divergence would not be surprising, but it's quite a significant convergence, ranging from a country like Sweden that up to now has basically remained in normal. They're just, I think yesterday, they're starting to announce some measures because of the seasonal activity. So maybe Sweden will be forced, maybe by their own majorities who don't quite understand the strategy, to actually intervene more. But up to now, they've basically stayed in normal. They've never left the normal. They're still a functioning democracy where people basically have almost all their basic rights in place. Then you have, as I said before, a range of countries that desperately now trying to go back to normal, who did have lockdowns, some of them severe lockdowns at some point, but they moved away or beyond that and said, okay, instead of just trying to hammer down on this virus, we within limits, we let it go. So we want to get back to normal as soon as possible. The US, of course, today happened to be the elections. We don't know. I don't know the outcome yet. It will take quite a few more hours, I think, to count all the votes. If Trump remains president, he is very much a back to normal kind of guy and wants to get back to normal as quickly as possible. If Biden wins, he is someone who will go into sort of what I call a muddle through mode that we see in Europe and in Canada, of intervening but not too much and desperately trying to get it right and never actually getting it right, and by doing so probably prolong the crisis in the US a little bit. But the president actually doesn't have that much impact on how the crisis or the situation evolves in the United States, because most decisions are anyway state level. So all Mr. Biden could do is try to lobby, especially the Democratic governors of states, to impose mandatory masks or other things that he's talked about. But how far that really would go, I don't know. I don't think the outcome of the presidential election will have a huge impact on how this situation continues to evolve in the US, except potentially around vaccines. If Mr. Biden, for example, insisted that the whole population has to be vaccinated, that would significantly then delay the sort of back to normal period. I'll talk about that issue around the vaccine a little bit later on. So Europe, UK, Canada muddle through, not quite clear, neither here nor there. And then we have a bunch of countries, mostly in Asia or Asia Pacific, that I call the new normal countries. So those are countries that really basically have embraced the virus and said the virus is now part of our, not embrace in the sense we just live with it, but rather we fight it as an institutionalized fight, right? They've institutionalized the war against the virus. And they seem to be destined, or they seem to want to be in this war for a long period to come. And they call this situation with a euphemistic term, new normal. But there's nothing normal about new normal, in my view. China, as I said, I don't really know, right? I assume it's in that bucket, but I don't really know. Okay, now these different sort of policy approaches, and it's very rough and ready what I'm doing, this categorization, I understand, but just to give you a flavor, it just leads to different outcomes in terms of how the virus progresses. So in the normal country, which is Sweden, there's now an uptick. Actually, the uptick now is steeper than it shows here as of 1st of November. It's just starting to go like steeply up. But, over the course of the pandemic so far, or the activity of the virus so far, we've seen a country like Sweden, where there was no lockdown and no major massive interventions on the part of the government, the viral progression is relatively smooth. I mean, it goes down a little bit in summer for sure, just because of the seasonal activity. We could already see that in Sweden, that there's clearly a seasonal activity. When the summer came, it started coming down, and now it's starting to go up again because of the winter, right? So we see that seasonal activity, but other than the seasonality, it's a relatively smooth curve. The level of infection of the population is now at about 17%, and it will take 70 months for Sweden to get all the way to what we call herd immunity. I'll talk about herd immunity separately in a moment. So this is a sort of a steady progression. Probably now with the winter activity spiking up, probably the next time I give you an update, it will not be 70 months anymore. It will be 50 months or 40 months. Because the extrapolations into the future are always based on the latest few weeks of data, latest days, 7 days of data actually. So it's heavily skewed now. But it's heavily skewed by the winter activity. So these data will change, but the fundamental progression in this kind of a normal approach, where you rely on each individual to do the right thing, to keep social distancing, but you don't impose any major government policies on people. You can see that this virus propagates naturally over a period of maybe, in the end of the day, it will probably be 2 to 3 years actually, if you include this winter season, which will accelerate things. But it is sort of a drawn out progression. The back to normal countries are countries that somehow or another, they early on clamped down on the virus, but not so heftily that it went all the way down to almost zero activity. They allowed it to proliferate in a certain way throughout the year. There's some going up and down, but on the whole, it's more like a, slide wave of, of variation. The US, other countries that are in the Northern Hemisphere, of course, are now seeing an uptick in winter. And some countries that are, so does Iran, for example, which also has experiences winter. But some other countries in this category, such as Brazil and India, are at the same time seeing actually a downturn right now. They're tropical or subtropical, and they don't really have that seasonality so much. Now you can see that Iran is, on current trends, will be at herd immunity within the next 3 months, meaning before any kind of vaccine could be reasonably expected to be available. And the other countries in the category, they will take a little bit longer, but they're all getting through the crisis sort of faster than Sweden on current trends. The muddle through countries, mostly European countries, they last time when I showed the data, they had much longer periods to herd immunity. Now that has been massively accelerated, especially in France and the UK, because in the last 7 days that I'm using as a baseline to extrapolate, there have been just massive increases in fatalities. And all of a sudden it looks like they could be through this rather quickly, but that is a short-term effect of the seasonality, and I expect that that will change a little bit again. They will take a little longer than 12 or 13 weeks to get through this, but depending on how significantly the new lockdowns and clampdowns on the part of those governments will be, it is possible that countries like France and the UK could be reclassified as sort of back to normal countries, because they are actually, at the moment, they're getting through this quite fast. Yeah, and then the new normal countries. I only have Japan in my model. I could have Korea and South Korea because there's some data, useful data for Korea, but I just chose not to. Their pattern is quite similar to that in Japan. And what you see here, so Japan being the biggest and most representative, perhaps, what you see is that it's moving very slowly, and it would take decades. On current trend, it would take decades for Japan to get through this crisis. Of course, this is always, unless there's a vaccine, it's effective, and governments on the basis of having the vaccines and vaccinating at least those people who they deem at risk may then declare an end to the crisis, right? So that could happen much faster, right? But in the absence of a vaccine and a highly effective therapy, on the current policy model, a country like Japan would take many decades to actually get through this process, this propagation of the virus through the population. Okay, and the world is currently at, as I said, about 1/3 of the world, ex-China, has now been infected, and it would take another 20 months for the world to reach herd immunity as a whole. That's an average for the world, right? Doesn't tell you very much about the individual country in which you happen to be in, right? As I said, but it's a global average. Okay, why is this global divergence a problem? I think I said most of these points before. Very asymmetric immigration and travel rules, meaning for years to come, especially thanks to the new normal countries, for many years to come in some places, we may have restrictions in terms of travel, and we will not be back to the normal sort of globalized, what we now consider to be normal globalization, where people can freely move around. We may not get back to that anytime soon, at least in some parts of the world. There may be distrust and breakdown of international order because of very different, very diverse policies and very diverse views as to what is acceptable, what is applicable, what is effective, and what is the right thing to do. It just reveals splits in humanity that probably were there before, but this situation just brings them into the light. How big the differences are in perspectives on how to handle a virus. Right? Something as simple as a virus. And I always say, well, imagine now we would like to align the world around something complex such as climate change. So I think after this experience, I would probably say that's going to be mission impossible, right? If you cannot even align around something as simple as a single virus, that most likely will turn out to be a common cold virus, as I say. Yeah, but instead we will be getting increasing distrust regionally between countries, between blocks of countries, and a potential breakdown of the international order. There will be a divergence in how dependent countries will be on vaccines. Some countries, as I showed on the previous slide, like Iran, they essentially don't really need the vaccine to get out of this. And maybe some other countries are the same. Of course, they still benefit from the vaccine. Being able to actually vaccinate those people at risk is always a good thing for any country, right? But it's more important for some than for others because some countries are already much further through this than others. There's this risk that I described last time, viral diversification into multiple local strains. So I gave the example of New Zealand, which prides itself of having kept the virus activity very low, which is great, except it means you can't open your country in any significant way, right? Because otherwise that whole sort of gain that you think you made will be sort of lost again. And if you don't open your country, it may mean, but mind you, New Zealand is just one example. There are many other countries in the same situation. It's just such a visual example because it's a remote island and you can visualize how that works. If they stay locked up for long enough, they will eventually, thanks to mutations, they will eventually have their own local variety of this virus, which may or may not be any longer compatible with the prevailing vaccines, for example. Which means eventually many countries may have to develop their own vaccines because their virus has mutated so much. I think that's not a very likely scenario, but still it's a plausible scenario. And the longer we keep our borders closed and keep certain groups of people separate from others, meaning what it means for the virus is we are creating separate ecosystems for the virus in which the virus will evolve differently through mutations. So the longer we keep those separate ecosystems going by keeping the borders shut, the more the likelihood that we get this diversification of the virus. So instead of having one virus, or today we have two strains, or not even really strains, but two varieties of it that are circulating. One of them is 10 times quicker than the other. I talked about that, which may be one explanation why some of these new normal countries may really have fairly low activity, because they may still have the original Wuhan virus type as a dominant type, which is slower, whereas, for example, Europe, North America, South America, probably Africa, probably India, have the faster variety. And that is a partial explanation why there's more activity visible there. But they are essentially, when it comes to vaccine, probably still more or less the same. But that may change over time, right? And so that is a real risk of keeping the borders closed, that we will have, instead of one virus, we will have many, which just multiplies the complexity of vaccines and treatments. And it makes it, of course, difficult for economies and businesses to plan and especially to operate internationally, et cetera, et cetera. So where does it leave us now? Yeah, we're deep into the fractured world. And I hope that my arguments demonstrated that, yes, COVID-19 is rather moderate, but the global response continues to be rather ineffective. Each country may say, oh, but it's the most effective thing we could do locally. But there is no such thing as effectiveness locally with a global virus. The virus is global, and it doesn't relate to human sort of imagined borders. Right? You can only really deal with this virus properly if you did it globally, right? Globally, and then, of course, locally. In each individual location where there's an outbreak, you can maybe do something, but the national level at which our policies are made is just completely the wrong level. And I think that's an interesting learning from this coronavirus affair, because that will apply to many of the problems that humanity will face in the future. The nation state is just simply the wrong mechanism and the wrong institutionalization of our responses and our actions in relation to challenges that come our way, including things like climate change, for example. Okay, has the world entered a permanent state of exception? I hope not. I fear that it may have. Okay, let us move on. Now we go a bit more into the current situation. How about seasonality? Being asked by people what to make of this sudden increase. I shouldn't say unexpected, because not at all unexpected, but sudden increase in activity in the Northern Hemisphere. Well, my response to that is we knew that winter is coming. It does every year, and even our calendars tell us that it does. So that is not a surprise. And arguably, we could not know for sure that this virus is seasonal, but we had every good reason to assume that it was very plausible that it would turn out to be seasonal. And of course, now we are pretty certain that it is seasonal. So this is a letter I wrote on the 10th of May. 10th of May, so in spring, to Frau Merkel, the German Chancellor. I've been sending about 24 letters to Frau Merkel since April, just giving her my perspectives on COVID and on possible policy actions. Not that I assume she reads my letters, she probably doesn't, and it's her prerogative, of course, not to read every letter that is sent to her. But if she had read my letter, then yeah, she would have known the winter is coming, right? Because after some preliminaries here, the main point of this letter is the winter is coming, right? And this was in May. Huh? So in May, I tell Frau Merkel the winter will come, and I give her 4 reasons. At the time, we did not know that the virus is seasonal. We could only conjecture that it might be seasonal, right? But I gave her 4 reasons why it was very plausible that this virus would be seasonable, and that this seasonality in winter would turn out to be tricky for Germany. This was a letter primarily relating to Germany because to Frau Merkel, but of course that applies anywhere in the Northern Hemisphere. And I summarized that argument by saying, expect a much greater circulation of the virus in winter compared to the spring, right? Then we were just in the spring and the activity had become fairly low. And I recommended to prepare with Germany to prepare on all levels. And by all levels, I meant, locally, I said, open all schools, all kindergartens, and all other activities. Let people, learn to live with the virus and practice the basic rules of distancing and washing their hands and not coughing, at each other and not sort of spitting at each other, right? Remember those basic rules, which are very important rules. And my advice was, take advantage of the coming summer, which is likely to be low activity anyways, no matter how we behave, just because the virus spreads much less in summer than in winter, on the proviso that it is seasonal. So my advice was just let everything go so that the virus can circulate, in a natural kind of fashion, and you get a higher level of immunization in the population before winter comes, right? In parallel, I said, invest in your capacities and capabilities, PPE, ICU beds, ventilators, personnel, training, etc., etc. And I said, set up support infrastructures at the level of the nation state, the national level, and the federal states and the municipalities. In Germany, the municipalities are actually the ones who actually act in healthcare matters. So they're really the point of intervention, right, locally, which is good, because the more local and focused your intervention, actually the more effective and the less disruptive it is, right? So I said, make sure that you strengthen those local municipalities with funding, with advice, with with competencies, whatever it takes, right? With staff, and make sure that the nation state doesn't do national lockdowns or anything like that, but rather just supports those localities in the right way, and leveraging the state level. A lot of healthcare policy is made at state level in Germany, just as it is in the US, right? So multi-tier, and I think just use those tiers to the most effective way you can. Some of which, to be fair, has happened. And lastly, 4th point, and coordinate at EU level and make sure that you have plans in place. If some country or region has a shortage in winter, has a shortage of ICU facilities or ventilators or such, or personnel, make sure you have plans in place how you can shift. Either you shift, talent, or you shift equipment, or you shift the patient, right? Which has happened to some degree, that Dutch or French patients have been treated in Germany, for example, right? Remember the EU's free movement of people, so make full use of that, right? And because not all parts of the EU are affected in the same way at any given time. There are always spare capacities somewhere. So if the capacity gets tight in one location, well, in the worst case, you ship the patient by helicopter or by TGV in France, or whatever, by plane, by ambulance to another location. And that, of course, applies within any kind of nation. But my argument was that should also be possible across the EU, given that we have free movement of people and everything else in the EU in principle, right? So I made some concrete suggestions. I mean, not very concrete, but just some ideas. Obviously, all of those would have to be fleshed out, et cetera, et cetera. I was quite disappointed to see that the German parliament passed a bill in, I think, about September, authorizing, I think, 6 billion euro funds to German hospitals to fund expansion or equipment or training or whatnot. The disappointment was just that was in September, right? I mean, that we should have done in March. I don't know why it takes 6 months to pass a bill that authorizes 6 billion euro, which is a very small amount given, what's the bigger scheme of things here. I was disappointed that it took 6 months to pass that bill because it means, of course, by the time those funds are used and dispensed, months will go by. In other words, it probably came too late for winter, right? But that's the thing about not preparing for winter. I mean, it was in May when I wrote the letter. That was the right time to really fortify the entire system and enlarge the entire system to be ready for winter. And I have to say, by and large, I do not think that enough was done. So my conclusion, my summary was, let the virus circulate over the summer when there is no risk or little risk of overstretching the healthcare system, so as to allow the population to get a natural level of immunization prior to the winter. And concretely, I recommended let go of the 50 out of 100,000 population intervention floor that Germany had defined, which just simply means whenever there were 50 new recorded cases out of 100,000 population, I think that was per week, local governments were supposed to intervene, either with local lockdown or quarantines or some combination of such measures. Right? And 50 out of 100,000 is a very low number. If you want to get a bit of immunity in the population, that's way too low a number. It was, I think, not totally arbitrary. I think the argument was 50 out of 100,000 is our maximum capacity of tracing. So the argument was, if the cases are no more than that, we are able to trace them back and therefore control the virus. But I've already made the argument that tracing in the previous video, right? The tracing in the case of this virus is not very effective. It has some effectiveness, of course, but it is nothing like the original SARS-CoV-1, where because it had a very different pattern of proliferation, super spreading events were the main driver of proliferation, and therefore tracing and then testing and potentially isolating had a very high impact on slowing down that virus and eventually actually eradicating that virus. But this virus is nothing like that in terms of its behavior. And so the whole idea of, we have to trace everything, and therefore, whenever there are more than 50 cases out of 100,000 population, we must, pull out the hammer again. Especially during summer, strikes me as extremely unwise, because it does the opposite of what you would really want, which is get some immunization in the population prior to winter, so as to smoothen, the winter curve, right? So I mean, in the beginning of this affair, people talked a lot about flattening the curve. Remember, that was sort of a buzzword. But the way to flatten the winter curve would have been to let it run a little bit freely in summer. That would have been the way to flatten the curve, and we didn't do that. Let me show you what actually happened in Germany. So I call it a brief history of misjudgments. This is Worldometer as of 1st of November, daily fatalities in Germany. The brown curve here is the 7-day rolling average, which I find useful. I'm grateful to Worldometer that they have that little tool that you can actually click on, and you see the 7-day rolling average, because it's sort of, since the recorded data is naturally a bit like zigzaggy, just because in some days there's more reporting than on others. On some days there's much less reporting than on other days, etc. So the 7-day rolling average just smoothens the data out, which is useful. So so let's look at that. So this is what you see here is the activity in March, April, and then the long, slow movement of the virus in summer, and then starting to increase again with the winter season now coming. These are fatalities. Again, remember, they have a 6-week time lag compared to infections. So if you wanted to map an infection curve against this, everything would, all this stuff going on here would have to be shifted by 6 weeks to the left, right? So I'll show you. I actually did that here. So the peak of death, according to the 7-day rolling average, was on 18th of April. And that implies that the peak of infections, which are not shown on this curve, but just imagine, the peak of infections were somewhere in early March. Yeah. So remember this, in early March 2020, Germany had reached the peak of the winter activity 2019-2020, so our previous winter, right? The peak of the activity was somewhere in early March, okay? On 22nd March, when fatalities were rising fast, Germany decided or imposed a national lockdown. Now, the national lockdown in Germany coincided with the end of last year's flu and seasonal cold season, right? In fact, it came after the end. The end is probably somewhere in the middle of March. So it came after the end of the cold season. So it was counter-cyclical to the seasonality of the virus. Now, again, to be fair, we didn't know at that time for sure that the virus was seasonal, right? So people will, if you challenge them on this, they will probably now say, "Oh, we didn't know that." Although I would have argued, well, many experts already at that time were saying it could be, and it's quite plausible that it would be. And also, we already knew at that time that the time lag was 6 weeks, so we could already at least anticipate that, okay, these deaths that we're now seeing, they are related to activity that happened 6 weeks earlier. So, hey, that's in the middle of the flu and cold season. So, I mean, one could have at least sort of drawn the preliminary conclusion that that looks very much like seasonal activity, right? But okay, one couldn't know, and that I accept. So the lockdown was done. What's interesting now is, now that the lockdown was done, meaning then infections really then drop off fairly quickly, right? With national lockdown, it does have an effect fairly quickly. Infections then drop off. You would then expect about 6 weeks later or so, or maybe it takes a few days to really have an impact on the infections, and maybe it's 7 weeks later. But by late April or early May, you would have expected a significant drop in fatalities, right? Around a bit here. Actually, we are not seeing anything like that. In fact, there may even be a slight, the curve here seems to almost be bulging a little bit up, which would maybe support my thesis that the lockdown killed more people than it saved, right? But that's statistically probably not relevant, so I won't say that too loudly. But clearly, there is no drop-off in fatalities here. So just visually, without running any statistical analysis, visually, I would argue the national lockdown had zero effect on fatalities at best, if not a negative effect. But let's say a zero effect. It did nothing it did not save any lives. Let's put it that way. Okay, that's what this analysis at least implies. Okay, now on 10th of May, I sent my letter to Frau Merkel saying, okay, this was at the end of after the easing of the national lockdown. So Germany had gone into a new system. As I said, 50 out of 100,000 was the metric. And if locally that metric was reached, then the local authorities were supposed to then impose a local lockdown or local other measures, right? And no longer any kind of national level. So, one thing that the government did learn is that national measures in a country with 84 million people, very diverse regions, and very diverse viral activity, and national lockdown is nonsense. Right? Nonsense. And I think they did realize that, or to a degree. They went towards a more locally managed model, which is more effective for sure, but it still breaks the same basic rights and liberties of people, because a lockdown is a lockdown, whether it's a national one or a local, right? It's still a lockdown, but at least it impacts much fewer people. Okay, so my letter, and then at that time we still had, let's say, about 5 or 4.5 months time window when I wrote the letter. And in fact, I could have written it a bit earlier, I mean, arguably, but okay, I wrote it on the 10th. So we had 4.5 months time to prepare for the next cold and influenza season, the one that we are now in, right? All this time here from early May until, let's say, mid-October, we could have done all the things I described in my letter, and maybe many other smart things that I didn't think of, right? What did the national and state governments do during the period? They continued doing local lockdowns, travel warnings, quarantines, mandatory testings at airports. Travelers were particularly the bogeymen of the summer. Oh, don't travel, travel, risk area, don't travel there. A complete madness of local mini regulations around tourism areas that massively impacted the tourism industry. Did nothing because the summer activity would anyways have been very low, no matter what. So it was a complete waste of GDP, if you like, and of livelihoods. And it's negative in that it does reduce the virus even further than anyways it would have anyways been low in summer, but it reduces it even further, so that now going into the winter, our immunization level of the population remains very low, meaning the winter will become very hard unless you do another crackdown, right? So it's almost built into the system that by now we are in trouble, right? The government, frankly, made it so. So, let me move my picture here and show you Frau Merkel's picture. So on 29th October, Frau Merkel speaks to German parliament. The situation is dramatic. Tja, Frau Merkel, you made it so. And move myself again. On 2nd of November, a renewed lockdown came into force in Germany. It's a less harsh lockdown than what we had in March, but it is still a fairly consistently, almost you could say, national lockdown, at least in certain certain parts of normal life. Right? Something that comes to me at absolutely no surprise. Would it have been preventable? I think so. I still think that those lockdowns do nothing, and we could have been better prepared, and we wouldn't need lockdowns even to get through the winter. That's my view, but I know that's a minority view. Okay, let me try to move on to the next slide. Yeah. So just quickly on that, just to make, and this is very iffy initial analysis. You'd probably be in a better position in a month's time to redo this analysis, but just for what it's worth, for a very initial view, on the left, 2 countries that didn't suppress the viral activity in summer very much. They did to some degree in some US states for sure, but on the whole, and in Sweden they didn't at all. And on the right, you have 2 countries in Europe, France and Germany, which did continue suppressing the virus throughout the summer, right? And here's what you get. As of 1st of November, and as I said, that's admittedly very early in the winter season, so in a month's time we will have better data, but the very early indication is that in Sweden, the daily death 7-day moving average as of 1st of November was actually less than the average during the summer. And in the US, it's just about the same, right? So there is, in other words, as of 1st of November, there is not yet a clear uptick in winter death in those two countries. Now they will come, remember 6-week time lag. So we are just very much at the very beginning of the death, the fatalities going up. They will go up in Sweden and they will go up in the US, there's no doubt. But so that's, again, that's why maybe it's a little bit early to do this analysis, but still in France and Germany, they're already way up. So you do see the difference, right? In France, fatalities in the first week, or in the week running up to 1st of November, is 20 times higher than the average during the summer. And in Germany, it's 5 times higher. Whereas in Sweden and the US, it's basically no uptick yet. So you already see a big difference, and the difference may actually get bigger in the next weeks and months, meaning those countries that let the virus proliferate through the summer will have much less of a strong uptick of activity in winter, meaning much less likely that their capacities, the healthcare system will be stretched to the limit than in those countries, France and Germany. But for example, there are others, those two are just examples, countries that didn't allow the virus to proliferate more freely in the summer, probably have very significant challenges in the healthcare system. And you're already seeing it now. Both France and Germany already declared national lockdowns again, right? And to be fair, again, at least this time, they're doing the national lockdowns at the beginning of the seasonal activity and not as they did in March at the very end, which is completely wrong timing. At least they might now argue, well, this time it will work better because the timing is right. We're doing it early in the, that will probably be the argument they would make. And there is some truth to that. But again, I'm not at all a believer in any kind of lockdowns. They're not needed. But okay. The bad news, given that we're going into lockdowns again and we will have chaos again, we will potentially again experience excess IFR, infection fatality ratios, being higher than natural because of the lockdown and all these measures, as we did in March. I'm afraid that may be the case. But the good news now conceptually is that we now really have clear evidence of seasonality, which buttresses our view that SARS-CoV-2 is just another common cold coronavirus. It is not a proof, but it further supports the hypothesis that that is the case. And that's in a way very good news, because if SARS-CoV-2 is just another common cold coronavirus, in the longer term, it will be completely harmless and unproblematic for us, right? And we don't know that yet for sure, but all indications are that's where we are heading. It will hopefully, if things go reasonably well, become just another common cold coronavirus that has no impact on our lives. Okay, that's at least the possibility. I should add, unless governments want otherwise, right? Okay, moving forward. Here are my initial thoughts on what can we do. In Singapore, just to talk about one country, as an example, 12.4% of the population is aged over 65. I'm using 65 here as a threshold, not because I'm necessarily arguing that's the right threshold in terms of when do you become an at-risk person. I would argue one would have to differentiate men and women, actually. Maybe men at 60 and women at 65 or so, but that is arbitrary, right, where you draw that line. And it's ultimately, it's subjective. Any individual decides whether they feel at risk or not, right? You cannot impose on an individual, you are at risk or you are not at risk, right? So, but policymakers, I will show, will probably need some, benchmark that they use just for practical purposes to execute their policies. And 65 is an age group that is commonly captured for all countries by the United Nations. So it's a practical, at least for me who doesn't have endless access to data, it's a practical limit. So 12.4% of the population is aged over 65. So one could say those are the people at risk. That's a very rough statement, right? Very broad statement. But 67% of respondents in Singapore, and this was a survey in September, are afraid, and this is the interesting thing, of catching the infection. This is the wording, yeah, of the survey, COVID-19. So of course, first observation, the one I made previously, COVID-19 is not the infection. There is an infection, which is an infection with the virus, SARS-CoV-2, and then separately there is an illness, which is called COVID-19, which on average 1% of those infected will develop, okay? So again, here we have that phenomenon of people, clearly even the survey company, not understanding that having a virus and being ill are two different things. There's a relationship between them, because if you don't have the virus, then you don't get that illness, that's true. But that doesn't mean that everyone has a virus will get that illness. That's not the case. For 99% of the population, it's not the case, okay? So that's one observation here, but the one that I'm now actually after is that although only 12% of the population could reasonably say, I feel at risk, of course, as I said, it's subjective, right? And in surveys in Germany, for example, 20 to 30% of people tend to say, I'm afraid, or I feel at risk, or something like that. I know it depends on how the surveys are designed and so on. It changes over time a little bit. 20 to 30% seems to be sort of the number. That in Singapore, it's almost 70%. Yeah. So there is something here about people, A, not making the differentiation between infection and disease, but probably also people just massively overestimating the danger. They are afraid of catching this virus, even though only 1% actually should be afraid. But of course, those 1%, they don't know that they are among those 1%. Right? So 20 to 30% could reasonably say, I feel at risk because I'm in that age group, or I have some prior condition or something like that, right? But this is 70%, almost 2/3 instead of 1/3, saying, I feel I'm afraid of this, right? So there's something here about psychology that is interesting. Now in this section, I want to talk about maybe we need to change our perspective. Maybe this fear that people, and I'm just picking Singapore because it just happened to have this nice survey published in September when I started to prepare this report. I could have picked another country. Again, there will be differences in terms of the fear factor among countries, but in all countries you will have a certain portion of people saying, I'm afraid of this, right? And usually they will say, I'm afraid of the virus, or they will say, I'm afraid of the COVID, and not making the distinction between virus and illness. Okay, but there is a fear. And the fear is about this virus being dangerous, or at least the disease it triggers being dangerous, and maybe an overestimation of how many people actually get ill from this virus, because most people probably don't realize that only 1% fall ill. So how can we change our perspective? So I have this little cartoon here that I found. So you can see a turtle lying on its back, and you know that a turtle lying on its back, that's bad because it's difficult for a turtle to flip over. Now, if you change your perspective, however, meaning if you stand on your head, you don't have to stand on your head, I'll do it for you, right? By just flipping the image. The turtle is up there saying, my God, I'm flying. So, to just change your perspective and you get a very different emotional response and a very different result, right? I show you again, right? Here's your little turtle flat on the back and unable to do anything, destined to die probably. And boop, you just flip it around and you say, oh. actually, maybe if I think at it from a different angle, the world is not such a bad place, right? I know this cartoon is not exactly fitting onto our situation, but I just like the cartoon. So let me tell you more concretely what I mean by that. We need to reframe, as my proposition, the problem statement. The current problem statement in many places seems to be that a dangerous, potentially fatal virus has befallen humanity. It's a problem of nature, and the virus is the problem. That seems to be the problem statement that many people implicitly have in their minds. Now I say, why don't we forget about that statement and instead say, human immune systems are degenerating and increasingly ill-functioning when facing novel viruses, including fairly harmless ones like this one. In other words, from this perspective, it's not a problem of nature, and it is not the virus that is the problem. The virus is a completely average, standard, normal, everyday kind of virus, okay? There is really nothing, as far as we can tell, there's really nothing particularly threatening about this particular virus. There are a lot more dangerous viruses out there than this one. We're quite lucky. We're quite lucky that it is such a harmless virus. Even influenza virus, I predict in the longer run, once we are through this initial phase where it's new, even influenza virus will actually be more dangerous for humans than SARS-CoV-2. For example, influenza virus is dangerous not only for the elderly, but also for the very young, the newborns and early infancy. Quite a lot of fatalities occur in the world among newborns and young infants because of influenza infection, usually pneumonia or some such complication of an influenza infection. That is not the case with SARS-CoV-2. For some reason, our young ones have no problem with this virus, which is very good news for parents especially, right? Our young ones have no problem with this virus. So certainly for the young ones, this is much, much, much more harmless than even the most ordinary influenza virus. Yeah, it's harmless. It's harmful for elderly whose immune system apparently is no longer functioning quite the way it should. And that's primarily just due to, presumably, I'm speculating, presumably just due to age, right? I mean, with age, the functionalities of our body tend to decrease, and the immune system is probably no exception, right? So, so it's largely because of age, and in some cases maybe because of some prior disease, or in some cases because of some genetic predisposition, autoimmune predispositions, or such things, right? I know it's a bit more complicated than the way I make it sound, but in principle, that's what it is in my view. It's just a question of our immune system. And so what looks like a natural occurrence, a virus came over and it's dangerous. No, it's a man-made problem insofar as we, by wanting to become ever older, and all of us do, right? And that's very natural and human. We want to live longer if we can. But it comes at a price, at a cost, and that cost, among other things, there are many costs, right? Environmental, et cetera. But one of the costs of this almost obsessive wanting to become ever older and being able through technology to become ever older is that our immune systems just degenerate as we get older, right? And we haven't apparently yet found enough means to keep them up. Maybe this situation will trigger a lot of research into how can we strengthen our immune systems even in elderly. Yeah, that could be an outcome. I mean, usually these kind of crises, they create opportunities for new thinking, right? But at this moment, we seem to be living with about 1% of our global population of people whose immune system is not capable of effectively handling this virus, and that's why we have a problem. So the immune systems of some people, small minority, but still significant, are the problem, not the virus, okay? So we should think of COVID-19 as having, two sides, like any good coin has two sides. One side is, yes, the virus, but maybe for a moment we should just accept the virus for what it is. It is what it is. It is probably a common cold coronavirus that is in principle harmless for humans, and it is only not harmless at the moment for some people because it is new to their immune system, and their immune system, because of degeneration of age or so, is no longer able to respond fast enough to the virus to prevent it from getting down into the lower respiratory system where it is dangerous. Yeah. The virus itself as such is not dangerous. It's a harmless virus. Yeah. It's the immune system, and that's the other side of the coin, the immune system that in some cases fails to deal adequately with this virus. Now, 99%, as I said before, of us humans have no problem with this virus. Virtually 100% of young people, virtually 100% of young people have no problem with this virus. But 1% or so of us, and mostly those are elderly people, do have a problem in that they're not able to prevent the virus from getting down into their lung, where it can be really dangerous. Yeah? So let's reframe the problem in 3 simple steps. Firstly, and this point, of course, I've made before, infection is not the same as disease. 100% will be infected, only 1% fall ill. Or put it another way, there's an entire population on the one hand, but that's not the same as the at-risk groups, right? And of course, my argument will be that we need to focus on the at-risk groups. Now, the at-risk groups will not be just 1%. Why? Because we cannot know exactly which 1% out of those elderly people are the ones who are unlucky, right? Because a large proportion of the elderly people doesn't have a problem with the virus, right? It's only a fraction, right? The older you are, the bigger that fraction, right? But it's only a fraction. But we don't know a priori who does and who doesn't have a problem. So we would probably have to take anybody who is 60, 65 and older, to defined as a risk group. And as I said before, ultimately people have to self-define and self-declare. And I feel at risk, and then we should take that seriously. If someone really feels at risk, with the appropriate education, yeah, so not the situation in Singapore with 67% of people say they feel at risk or they fear the infection, which is really unnecessary, right? But with the appropriate level of information, maybe that percentage would be 20 or 30%, right? But those people who say, I feel at risk, whether they're older than 65 or not, we should take them seriously, right? Because that is a subjective choice that people make, or a feeling, right? Whether they feel at risk or not. You cannot impose that. But certainly, it is not 100% of the population. It is a lot less than 100% of the population, certainly. Second, we should just take the virus for what it probably is. As I said, it's probably just another common cold coronavirus. It doesn't kill us. I said that before. The virus is not fatal. Maybe I should really say that out more loudly. This virus does not kill anybody. Our compromised immune systems kill. Okay. And if it's a CCC, then we can hope and assume that once you've been infected once, whether it's naturally through a natural infection by the virus or artificially through a vaccine that mimics aspects of the virus, relevant aspects of the virus, we may get reinfected repeatedly, as is the case with common cold viruses in general, right? Every so often we can catch the same virus again and we get a cold again. And the virus, the cold is a complex cocktail of viruses. There are many viruses involved, not just one, but we can get this very same coronavirus again and again and again. The initial research so far suggests that antibodies will stick around probably for a few months. T cells will stick around for at least 6 months, they found recently, and maybe longer. So it seems that nature has preordained that within a single winter period or a seasonal period, we shall not get infected twice. Maybe that would be too much for the body to bear. So the immune system is ready to keep active antibodies and T cells in the blood, ready for a period of a few months, up to 6 months or even a bit longer, just to take us through the entire winter period. So even if you get infected at the very beginning of the winter period or the seasonal activity, and that activity goes on for about 6 months until the flu and cold period is over for that year. During those 6 months, we will not get infected a second time. That seems to be how nature, or how our immune system is working through this. Right? You shall not get reinfected within the same seasonal activity, right? But 1 year later, when there's the next season, you could be reinfected again, because by that time, the body has not bothered to keep those antibodies and T cells active, right? Now, but we are unlikely to develop severe symptoms ever again. And that's probably even quite independent of whether the first time we had severe symptoms or not, right? There may be differences. We don't know yet. If you had a very light infection, how much antibody and T cell stuff do you really generate? Yeah, there's still a lot of open questions for sure, for research, and it will take years to get through all of that. But with a bit of luck, and again, using the common cold coronaviruses and other common cold viruses as our analogy, you almost never get really sick of a cold. There are cases, exceptional cases, but those are exceptions. As a rule, we never really get sick of a cold. We get a cold 2 to 4 times a year as adults, and children even more frequently, but we don't really get sick. We may not feel so well for a week. We may skip 1 day of work or school. We may have a headache, lie down a bit. We may have a slight fever. We are under the weather, I think is the expression in English, right? But we are not really sick. We don't normally seek medical help, and certainly we don't need hospitalization. So that doesn't really count as a disease. Yeah? It's an inconvenience, really. And so hopefully once we've been exposed to the virus once, or the vaccine as a simulacrum of the virus, we can be reinfected repeatedly with the same virus, but hopefully never really get sick of that. So it just becomes part of our normal common cold corona, or common cold cocktail, as I call it, the cocktail of viruses involved in our common cold. How about mutations? We don't really know. I mean, most mutations tend to be in our favor, not in our disfavor. So that is, I think, an important point to keep in mind. Mutations are not per se something that is scary, because mostly the mutations that come through the phenotype of the virus or of our immune system, because our immune system may change, right? So they tend to be adaptive, right? So the adaptation to each other gets ever better, not worse. Right? The virus has no interest in killing us as hosts, right? And it's actually no interest to get into our lung, because although it can replicate there, it's very hard to transmit out of the lung because the way is much longer. That was the experience of SARS-CoV-1. SARS-CoV-1 didn't transmit very easily because it only colonized the lung. It was not really able to colonize the upper respiratory system, which are much better from the point of view of the virus in terms of spreading. Right? So the virus doesn't really have a big reason to want to be in the lung, right? It gets into the lung by mistake, so to speak. The virus doesn't really want to get there, and our immune system doesn't really want it to get there, but for a few people, the immune system just isn't up to keeping the virus out, and the virus just sort of ends up in the lung without really having any purpose. Viruses, of course, don't have purpose anyways, but you know what I mean. And from the point of the virus, and the mutation is, insofar it's translated in the phenotype of the virus, it's driven by what works for the virus, right? So the virus wants to be in the upper respiratory system where it can transmit much more easily. That's really the purpose of the virus, right? So with a bit of luck, once we've been exposed to it, we may not keep the antibodies and the T cells for very long, but we keep a memory, a blueprint, if you like, of how to manufacture these concrete, specific antibodies and T cells that are the right response to this particular virus. Our immune system keeps a record, right? A blueprint of them. And so next time the virus comes, and let's say, 6 months or more have passed by, so we no longer keep any antibodies or maybe even T cells ready in our blood. But when the virus comes and it gets into the upper respiratory system, because there's no antibodies right away to keep it out. So it gets in, it does colonize, but already the colonization of our upper respiratory system will be slowed, because then immediately the body starts reproducing those antibodies, right? So we cannot maybe prevent the virus from infecting us, but already when it's in the throat or in the nasal cavities, we already start attacking it. Our immune system does, right? And it keeps it, this is a layman's way of thinking about this, it keeps it already under control and minimizes the likelihood that it will get further down. Right? That is what I would think is the plausible scenario here, right? Which means we will be reinfected with this virus again and again and again, but we will almost never have to fear that we could get seriously ill from it. Which also means that herd immunity, in the classical manner of saying 60 to 70% of the population will have immunity, will never come about, because by the time the early people who had the infection early, the later people who have the infection later, by the time they get infected, the early ones already no longer have the full protection, because the antibodies are already disappeared from their blood. So we'll never, reach 60% or 70% of the population, right? Just because of that. By the time the next cohort of people has got infected, an earlier cohort from 6 months ago has already been dropping out again of those who are fully immunized, right? So we'll never get to a point where we can say we have an actual herd immunity, at least not at the level of infections. At any given time, even 10 years from now, 50% of the population could be infected by the virus, or within a season. That may well happen. However, on the level of developing severe symptoms, we may have full herd immunity. I mean, almost 100%, right? Meaning, once everybody has been exposed to the virus, almost nobody will develop severe symptoms that are, in the lower respiratory tract where they're dangerous. And I'm not saying it is like that. I'm saying it is plausible that it will be like that, and we should think of it as a hypothesis, as a straw man. We should think of it this way. Okay, next, therefore, we need to shift our mindset. We've been talking a lot, or policymakers have been talking a lot about disrupting the chain of transmission, by which they mean from me to you, right? Instead, I'm arguing we need to disrupt the chain of progression, by which I mean from my upper respiratory system into the lower respiratory system. Yeah, the virus is not dangerous in the upper respiratory system. It's harmless in the upper respiratory system. It just creates a bit of a scratch in the throat, or a bit of, some people have symptoms such as their sense of smell is impacted, and there are some other symptoms, but they are basically light symptoms. But it's not dangerous in the upper respiratory system. At least that's my contention. If the experts think otherwise, then they better speak up. But we need to prevent it by all means from progressing further down. Because when it comes into the lung, into the lower respiratory tract, then it becomes dangerous, right? So it's not about, the priority in my argument should not be about stopping a transmission from one person to another, but rather doing everything that within each of us, the virus will not progress further than here, Okay, we keep it up here, it's okay. We just don't want it to get further down. Okay, that's the argument here. So the current policy focus, or the current thinking is that the virus is immediate, sort of, the virus leads to disease. And so the current policy focus is on battling, fighting, going to war and suppressing the virus. And the primary focus of vaccine development is on preventing the virus to even settle inside our upper respiratory system. So a full immunization from any kind of infection with this virus. Right? That's the current primary focus of most vaccine development, not all. And then, of course, on the other end of the progression, you have then a quest for therapies for those people who actually get really diseased, right? That is also going on. Now, my argument is that between the virus and the disease, in our mental model, we need to recognize that there is an immune system in between, right? Which, again, in 99% of all cases, prevents the virus from turning into a disease. Because physically speaking, it prevents the virus from getting any further down than here. Okay? In 99% of all humans, the immune system does its job, which is great news. I think I said that on my previous video. This is great news. In 99 or more cases, our immune system works fine, and it does its job. And we're really only concerned with those 1% or less cases where, unfortunately, it doesn't. Right? Okay, so once we insert the immune system into our mental framework, we can ask, isn't the true value of the vaccine rather in sort of permitting our immune system to prevent the virus from getting from here to here? Isn't that really the important objective for our vaccine, as opposed to preventing the virus from getting any further than this, right? Right? We say, no, as long as it doesn't get any further than this, it's fine, right? So it's a different emphasis for the vaccine. It may also mean to put more emphasis on any kind of prophylactics. I'll talk about a couple of possibilities there, but that's beyond my area of expertise. But if it's okay for the virus to get into our upper respiratory system, meaning, you know, we start maybe even having some light symptoms and thereby noticing at some point that, oh, we may have COVID, maybe you get tested, then yeah, you have COVID. In that moment may still be soon enough to apply, you know, prophylactics that prevent the virus from spreading further. Or if we know we are at risk, you know, we have a vitamin D deficiency and, you know, all kinds of other things that are potentially correlated with, you know, slow immune responses, then we can even apply prophylactics even before we get infected, right? I mean, some elderly may, or people who know they have a vitamin D deficiency, they may just want to take the appropriate amounts of vitamin D as a pill or something, right? And there are other things that one can think of. So if the problem isn't really here, but the problem is really here, then it gives us a window of opportunity to apply much more prophylactic things, right? Which include the mask. I will talk about the mask in a moment too. Because the mask, yeah, I'll talk about that in a moment. So instead of focusing just on getting the virus, keeping the virus away from everyone, we could then be much more targeted in our approaches on, you know, the at-risk groups, right? Recognizing that it's the immune system that is the problem, and only some immune systems, we can then ask, what can we do up front for those people who are, you know, who are at risk, right? And we don't need to insist that everybody has to be kept away from the virus. I said earlier, there are good reasons why that's a bad policy, right? Not allowing people to expose themselves to the virus means they cannot train their immune system. They cannot learn to live with this virus in a natural way. They can never go back to normal, right? They will forever then be condemned to live in a new normal. I don't really know whether that's desirable, unless maybe the vaccine comes and does the trick, right? We will see. But again, the longer we keep the virus away from us, actually the worse we may make the situation. There's a real risk of these policies of suppressing the virus being highly risky for people. So disrupting the chain of progression is my argument instead of the chain of transmission. What does it mean in practice? Okay, let's look at the upper and the lower respiratory tract of a person. Let's say this is an at-risk person, 65 years, male, let's say. First observation is that from what I've seen, about 50% of infections are believed to take place through the nasal cavity, meaning the first colonization takes place in the nasal cavity, or it comes into the pharynx, into the throat, into this upper part of the throat here, or the back part of the mouth, through the nasal cavity, and another 50% comes through the oral cavity. There's maybe a small proportion that comes through the eye tissue, but that's probably quite small. I haven't seen anything that suggests that it's not small or tiny. So, the first screen, if you like, here, this black screen that I painted here, would say, well, can we prevent the initial infection? That's what we've been prioritizing, what most governments have been prioritizing. Social distancing, for example, and wearing the mask, right? I made the argument last time that surgical masks may well have above 70% efficacy in preventing an initial infection. Come back to that. There's things around routines in care and old folks' homes, setting up routines such that as to minimize exposure to, infected people. Self-testing in those locations and also at home. If you're living with, especially an elderly person, can there be a quick and cheap or free test that you can do regularly every so many days, for example, just to make sure you are not infected when you're interacting with that elderly person, right? The vaccination, when it comes, it will, according to CDC and other organizations, have at least 50% effectiveness or efficacy in preventing an infection. Otherwise, they would not let it pass the test, the certification requirement, so to speak. And then, as I said, are there some prophylactics, plasma prophylactics, meaning you inoculate a person with the blood plasma of a person who already had the infection and therefore will have some of and had it fairly recently, so they will have, antibodies, including neutralizing antibodies, etc., in their blood, and you can take their blood plasma, inject it into a at-risk person. That's not straightforward. It's ethical questions, how effective are the risks, etc. It needs to be studied. It is being studied, but the point is there are things we will increasingly learn to deploy even at this first sort of stage, right? And as I said, immunoboosters, that would include things such as vitamin D and other things. And how effective they really are unknown, but probably no harm. Yeah, I mean, if you know you have a vitamin D deficiency, vitamin D being important to keep the immune system in good shape, then now is a good time to rectify that. And there are ways to take a pill. You need a certain quantity. It's not trivial, but you need a prescription for that for sure. It's not just going to your supermarket and buying some pills, right? It's going to your doctor and saying, first of all, figuring out if you have a vitamin D deficiency, and if the answer is yes, you do, then the doctor will tell you what to do, right? But yeah, that is certainly something that wouldn't be wrong to think about, right, at this stage. Now, second stage, that's the key one, I argue, is those about 1% of all cases where the infection goes from the upper respiratory tract, past this sort of imaginary barrier here, which I've indicated with a black bar, right? It's an imaginary barrier, but it goes from up here down there. And especially then, this virus unfortunately has the property of enjoying to colonize the alveoli, which are these air sacs in our lung where the oxygen exchange takes place. So they are vital. And that's the unfortunate thing. That's why so many people asphyxiate or need oxygen and then even ventilators because they're not able actively to breathe enough to get enough oxygen to keep themselves alive. Right? And that happens if the virus massively invades the alveoli, and then the body mounts a massive immune response, and the immune response often is then the really dangerous part. If it's either it's over responding, you get cytokine storms and those types of nasty things, or it's underreacting, it's misreacting. The inflammation of the lung tissue means that the body starts killing and removing those cells that have been infected. But the body is not always 100% precise in this sort of cleanup work. It's like a bit like a bulldozer going around, and you're trying to really mend your little flower garden, and you use a bulldozer. You can picture that is not so finely tuned, and unfortunately, the immune system sometimes is like that. It may bombard the body's own cells with attacks that are just simply going overboard and doing more damage than they're doing good, right? And that is one of the reasons then it becomes fatal. Now, how do we prevent the virus from getting down there? Well, first of all, again, surgical masks. And here's the important hypothesis. The surgical mask, based on my calculation that I shared last time, may only be 70% or so effective in preventing the virus from getting into the body, but it may be more than 90%, maybe close to 100% effective in preventing the virus from getting further down. Why? Because surgical masks are extremely effective against droplets, and droplets are the biggest particles that are at stake here, and they carry the biggest viral load. And they're also fairly effective against other sort of biggish particles in the air, and only the very small particles sometimes get through the mask. Yeah. Now the smallest particles also carry the smallest viral load on average, right? So while the mask may not be 100% or not even, let's say, 80% effective in preventing those small particles from getting inside your mouth, your throat, they may be almost 100% effective in preventing it from getting any further. Why? Because the quantities that get to settle and colonize into your upper respiratory system will be small, thanks to the mask. So they come, but they're small. And the smaller the quantity, at least some evidence that I've seen suggests, the smaller the quantity of the virus that colonizes your throat, the higher the probability that your immune system, even if it's a compromised immune system, that your immune system will have enough time to mount the appropriate response to prevent it from getting further down. So the surgical mask may have an okay effectiveness when it comes to preventing the initial infection, but it may have a very good effectiveness in preventing the viral progression down into the lower respiratory tract. That's the key. And the same for the vaccination, right? As I said, CDC may say we will certify vaccination if it has at least 50% efficacy, and they mean efficacy in terms of preventing the infection. But that same vaccine may well have near 100% effectiveness in preventing the virus from getting any further down. So again, just like the mask, it may not prevent the virus from getting hold of you, or you're getting hold of it in your throat, but it may be very good at preventing it from getting any further down, meaning you don't get sick. You have a mild cold or something, but you don't really get sick with COVID. Right? Now, there are other things, prophylactics, at this stage, antivirals come already into play, right? Antivirals as a prophylactic over here, I haven't seen anybody really claiming that by taking antivirals as a prophylactic before having been infected, that you can significantly reduce the likelihood of catching the infection. But I do think, from what I read and hear, that antivirals may be effective in preventing the progression further down, right? Because just like the surgical mask and the vaccination, they just reduce the amount of virus that's there and give, hopefully, I don't know this for certain, but hopefully give the immune system more time, therefore, to mount its response. Yeah? It will not be 100% effective. In some people, the virus somehow will still get through. But you just, with all of these measures, you may be reducing the likelihood of the virus getting through, down to a very small level, which is what we want. We will not 100% exclude the possibility of a fatality from COVID. We will not, never, right? But we will get it down to such a low level that it just becomes part of our normal fatalities, mortality that we, anyways, as human beings have, and nothing to be too worried about, you see. So some of these I've put a question mark. I don't know exactly, but I can think of a lot of things that might add to our capacity to prevent the virus from getting further down into the lower respiratory tract. And that's the key. And that is, in my view, not discussed sufficiently in the discussions that I observe, that is actually the key step and not the first one. That's why I'm highlighting it and spending so much time on it. Sorry. So, about 0.2 to 0.4% require intubation, meaning on the ventilator, and half of those end up dying, right? So then by the time you get onto intubation, that's a bad sign. Then you're really at high risk of fatality. And of course, once the virus got through and it is in the lung, then we have all these treatments and means that we're working on to either treat it or reduce the symptomatic, right? And you've heard remdesivir has some impact on reducing the symptomatic at this stage, but there's no clear evidence yet that it reduces the fatalities, et cetera, et cetera. So that is all evolving, right? Steroids, we have dexamethasone, which shows some initial promise, possibly in reducing fatalities at this stage by about 30%, which is a good, which it's not 100%, unfortunately, but it is, if it's 30%, that's, it reduces our IFR from 0.1 to 0.2 to something like 0.07, sorry, to 1.4 or something like that. I mean, that is a significant 1/3 improvement, basically. So if that is the case, right? And, these things are still being tested. Some of them are starting to be rolled out. But I think the trajectory is we will increasingly have a mixture of things here that will reduce the fatalities at the back end. But really the point that I'm making is the key is step number 2. That's where we should be focusing, in my view. And that is something I haven't really seen happening sufficiently. Even in the scientific papers, people, when they talk about vaccines or surgical masks, often do not make the distinction between preventing an infection and preventing a progression of the virus into the lower respiratory tract, where I would argue that's the key distinction. Yeah, but even scientific papers, sometimes I get the feeling they don't understand that this is not the same thing, because step number 1 is you get a cold. Step number 2 is you get pneumonia. You see, that's very different. Pneumonia can be fatal. A cold is never fatal, almost never fatal. It's only fatal if it turns into pneumonia. But so if you prevent the cold from turning into pneumonia, the cold itself is never fatal. So this distinction we have to make, right? And we have to, our interventions and our research need to be built around that. That's my contention. So I have here a few action items in blue, what things we can do, but let me not dwell on that. Let me give you one quick practical example, just as an initial attempt. In practice, what would we do? Well, we would have to define eligibility for at-risk support. So who is at risk? Who do we define to be at risk? My argument is there's probably going to be an objective criteria gazetted in the public that says, okay, either by age cohorts, maybe different by male or female, and a list of the eligible preconditions. So, a medical practitioner would have to attest that, yes, this person has that precondition here, and that precondition means that person is officially considered at risk, right? Even if they're not in the right age cohort, right? Even if they're younger, they can be at risk if they have a certain precondition, right? And we may possibly have some kind of hierarchy of priority that we say, well, number one priority in our measures is those who are above 80, number two is those who are above 70, and number 2A is those who have certain preconditions, and then number priority three is those above 60 or so. You see what I'm saying? You can, within those at-risk groups, you can prioritize further. And yes, this will always be a little bit arbitrary, just like the arbitrary decision that when you're turning 18, that then you count as adult in the face of the law is purely arbitrary. It could be 21, it could be 24, as it has been in the past in some countries, right? It could be 16, but we just decide in most countries it's 18. But that's an arbitrary decision, but it is important to make that, to define that cutoff, because once you're older, you fall under a different legal system than when you're younger. Because for young people, we have milder legal repercussions if you get into trouble, right? And most people will probably say that's good, so, that we have that, and yes, we have to draw the line somewhere, and yes, it's arbitrary, but there it is, right? It's arbitrary, but it's publicly notified, so everybody's aware of it, right? And the same probably we would have to do here. But then my argument is, in addition to that, there should also be that subjective self-selection, that anybody who says, look, I don't fall into any of your categories, but I really feel at risk and I want to be treated like that, then we should take that seriously, right? And no matter what the reason, right? Again, with the appropriate information, so maybe one has a talk with the person and said, look, why do you feel at risk? And if you then tell the person, but your risk is very, very low, you're 20 years old, there's no preconditions known, I mean, your risk is very, very low, and then maybe the person, oh, okay, then now I'm relieved and maybe I don't need any special treatment, right? So there's an information step perhaps in between. And yes, it requires a lot of logistics, et cetera, I know, but it's all possible. Okay. So we have defined a set of criteria by which we say this person's at risk. So let's take an example, and I picked an example of a real person who is 46, so does not fall into the obvious sort of elderly category, but this person is a dialysis patient, meaning the kidney is malfunctioning and the person needs 3 visits to a dialysis center per week. The person also works as a teacher at a children's school, has a wife who works full-time and travels normally in normal times, and has 2 teenagers living with him at the same home. So this is our case profile. So here we have a person, and now we can think about, well, how could we effectively protect this at-risk person? The reason he's at risk is because he's a dialysis patient, and dialysis is a risk factor for sure, irrespective of your age, right? So we would have something like a public registry where we have, medical practitioners who are certified, who would review the health status of this person, and they would decide either, oh, this person is not at risk, he doesn't fall into any of our categories, or, oh, yeah, he's got dialysis, yeah, he's in principle at risk. We could then have, an antibody test, and and say if he has positive antibodies, he's not currently at risk. That's probably a risky proposition. So maybe I would take that out of my model. But it's just an idea that someone who has antibodies, therefore, might then be declared free of risk. Now, as we know now, the antibodies don't last very long. And we don't also know so far how effective they really are. So maybe that's a bit of a risky proposition. But it is possible to think about, hey, so many people now have antibodies already, and they have them for a few months at least, and some of them maybe for quite a bit longer, maybe for 1 or 2 years even. Let's not put them on the at-risk list if we know they already have antibodies. They've already gone through the through the disease not the disease, but the infection once. And our hypothesis being they will probably never really be at high risk. But maybe we want to really get some empirical data on that before we make clear choices there. But, it's at least a thing to consider that someone who tests positive on an antibody test, was, this person already has been infected. So maybe we don't give them the at-risk status automatically. Okay, but if you test negative, which is in most cases, then we could declare that person at risk, and then the medical practitioner issues a certificate, maybe electronically via QR code or an app or what have you, and informs the relevant life environments of this person, including I call it the work hub, so the school at which this teacher teaches. So that teacher, for example, should be free to wear a mask, and may get services such as personalized transport to the school 5 times per week, to his workplace, so that he doesn't have to use public transport unless he has a car. If he has a car and drives himself, that's fine. Then there's a personal hub, so can we, for example, supply free oxygen dispensers to his home, maybe also to his school. So, the school and the home have a certain supply of oxygen. So if the problem does arise, he can immediately at least get oxygen, which is, we know is critical for people if they all of a sudden have breathing problems, right? And so on. There are other ideas. For example, can we supply free and simple self-tests to all family members? So if any household where there is an at-risk person, an elderly or a person like this dialysis patient living in a household, his wife and his 2 teenagers should be supplied with a regular supply of free testing for the virus. So they every so often, maybe every 5 days, 7 days, experts can figure that out. They should do a self-test just to make sure they are free of the virus. That that would be a simple measure to keep the environment in the personal hub, relatively safe for this person, right? And then, of course, there's the healthcare system where you have hospitals, you have the dialysis centers, you have government-mandated agencies that supply for prophylactics and vaccines, etc. Once we have the vaccines, and government-mandated suppliers of equipment, as well as services. For example, this case is in the Philippines. Grab or Uber or such services, you may be government certified to be personal transport providers to people at risk between their home and their workplace, and between their home and their healthcare system provider, for example, right? So these things cost money, they cost organization, they may not in all cases be realistic, but all of these things could be done to make this person as safe as possible, even as the rest of the people around him pursue a normal life. That's the idea. So I leave this example with you. I'm sure there are many details that are tricky and need to be worked out. Some of this may turn out to be quite expensive, especially in less developed countries. But there may also be other great ideas that I haven't even thought of. But in principle, I hold it is possible to protect, with all these measures that I've described, protect an at-risk person quite well, either from getting the infection in the first place or from the infection then getting further down, without having the rest of the population being in a permanent state of exception. That is the main argument here, all right? Now, the question I've been asked is, isn't everyone wearing masks even better than only those who feel at risk wearing them? And the answer is, first of all, the surgical mask is probably highly effective in preventing infection as well as disease, right? And I remember I had this chart before. I compared surgical masks efficacy with that of the expected vaccines. And I pointed out that as long as people actually comply wearing those masks in public spaces, and admitting that there's an inconvenience to that, but as long as people wear it properly over the nose and the mouth, the efficacy of surgical masks may actually be as high or similarly high as the vaccines we're all hoping for. Yeah? I think that's a very important point to make. So even the at-risk persons themselves wearing the mask does probably provide a fairly high degree of protection. Yeah? And yes, if both sides wear it, so whoever they're interacting with also wears it, then it's even more effective. That is true. But the marginal effect of that additional protection will not be that terribly high, given that one mask is already quite, the one-sided wearing of the mask is already quite effective, right? So the marginal gain of the other person also wearing the mask, it will be there for sure, it's measurable, but it's not potentially not that high, right? Especially if the person who is at risk wearing the mask also keeps some distance, which is not always possible in every situation. And if you're at home, you're an elderly, you're at home, you have children around, you want to hug the children, naturally, right? And certainly, I'm not saying you should not, right? But maybe those children have been tested every week, right? And continue to be tested every week. The second person with whom you're interacting is if you're the at-risk person, interacting with staff in the hospital, staff in the old folks' home, your family members, etc. In very specific circumscribed situations, it may be right for that person to also wear a mask, right? Even to mandate that. So in high-risk workplaces, such as old folks' homes and care homes, I would argue it might be appropriate to actually mandate wearing a mask as part of just the working conditions. Just like in construction jobs, people have to wear a helmet. It's just mandated, right? And they accept it, and if they don't accept it, they need to find another job, right? I think that is, in a workplace-related situation where there's a known specific risk, I think it can be mandated to wear a mask. But that's just about the only place, I'd argue, where you could mandate wearing a mask. So it should not be generally mandated, because mandating the wearing of a mask, apart from this not being very effective, it arguably comprises an impermissible infringement of the integrity of one's body or movement, right? Movement in the sense that, you're not allowed to enter this building unless you wear a mask, right? You have those kind of restrictions. So it's not only an infringement on the integrity of your body, but also it limits your movements, right? If you don't comply. So my argument is it's ineffective as a general means, outside of those specific situations where the person who is at risk themselves, they may choose to wear the mask, and that's a good idea in public places, right? But all other people don't have to wear the mask. That's not necessary, and the effect on reducing the risk for that person who is at risk is probably fairly low. And at the same time, the infringement on your physical integrity is high. In my personal judgment, and that's a personal judgment to make, yes, I'm not a policymaker or a lawyer, but in my personal judgment, that is completely out of proportion to mandate the general wearing of masks. How about solidarity? Some people tell me, but when we all wear masks, this is a sign of solidarity with our elderly people. And the answer to that is solidarity cannot be mandated. It is by definition voluntary. So if you want to show solidarity, the first thing you would have to tell your government, please end the mandate. Because by mandating the wearing of masks or other such measures, the government prevents you from showing solidarity. You cannot show solidarity if it's mandated, you see? So if you really feel you want to be able to show that solidarity, that's great. Then the first thing you will have to do is to tell your government, drop the mandate, because only then can you demonstrate your solidarity. And I think people get mixed up there. They say, oh, by mandating it, aren't we all showing the solidarity? No. If it's mandated by the government and, supervised and, with fines and, all that, then nobody is then in a position to show any solidarity, by definition. Okay, so if you're keen on solidarity, which I understand, you need to create the circumstances in which you can show solidarity, and that means get rid of any mandates. Only then solidarity starts. So in practice, what we need to do, in addition to the things I said, is dispel some, common policy fetishes, I call it, and some popular myths, what I take to be myths, this is my opinion, about the situation. Number one, the virus is dangerous. No. Compromised immune systems are dangerous. So this requires a societal debate. We need to recognize that our aspiration to get ever older comes at a cost. And one of those costs is a compromised immune system in some cases, not in the majority of cases, but in some cases. And we cannot, in my view, put the entire human society into a permanent state of exception, because a small fraction of us, by virtue of getting ever older and older than nature ever intended, are at risk. That is the wrong way to think about. Yes, we all want to get older. And yes, if we can do things to improve our immune system responses, let's do that. Let's invest money in that, by all means, right? But to imprison people at home or in their quarantine or whatever, just because some people have a compromised immune system because they are older than nature had, in store for them, is, in my view, completely unethical. So let's be clear where the danger lies. The danger lies in us getting ever older, and maybe our medical technology and science not always able to keep up with doing the things that would allow us to get older without a compromised immune system, right? That needs to be discussed, and then we need to think about what can we do. And is it really so glorious that all of us are getting ever older? I mean, there are other reasons why that may not be so glorious, right? But this is one, right? So let's just be mindful of what's the real problem. The virus is not the problem. The virus is not the problem. It's a human problem. So let's discuss it as a human problem. We must break the chain of transmission. No, I said we must break the chain of progression in those people who are deemed at risk. The hammer is necessary. It saves lives. I said there's no evidence that the hammer saves any lives, and probably it does more harm than good, all things taken together. We must wear masks to protect others. We may choose to do so. Yes, certainly anybody is welcome to choose to do that. But certainly we shouldn't mandate it. And instead, we should encourage those who are actually at risk to wear their masks. I mean, I do get a little bit upset being forced to wear masks just about everywhere I go, and then seeing primarily elderly people not taking this very seriously. So they have their masks sitting, first of all, they don't use proper surgical masks. They use some, I don't know, reusable, washable thingy, textile that probably only does half the job. That's the first observation, right? If they're using the wrong mask often, not just because they're old, also younger people also use the wrong mask. But I'm focusing on the at-risk people. They should get the right mask, which is surgical masks. Those things work, right? That's why they are used in operating theaters around the world, because they work. So they should get the right mask. They should wear them properly, right? Ideally, and then it takes some encouragement. And if they really insist on, not doing it, that's up to them. I mean, let's treat our elderly like adults, right? because they are adults. And unless someone has dementia also, in those cases, then maybe a family member has to make those choices. But if a person says, I don't want to wear a mask, then that's up to them, right? But we should encourage those people who seem to be at risk, or who think they're at risk. We should encourage them to protect themselves wherever it makes sense. The vaccine will save us, and we must wait for it. And in the meantime, just lock everything down and be in a sort of permanent state of viral suppression. No, the vaccine is just another part of a comprehensive approach. It's an important part, and we all like to see the vaccines coming, but there's absolutely no need to wait. We could end this state of exception now by just supplying sufficient quantities and quality of surgical masks to all people in the world who are deemed at risk. Let's say 30% of the global population, they would just get surgical masks supplied to them on a daily basis, right? I know logistically that's not so easy, but it can be done. And it's much cheaper than destroying our economies, much cheaper. So we could end this today. We don't have to wait for the vaccine. The vaccine will make it easier to get through, for sure, but it's not really required to get through. And then lastly, there's always a sense that responsibility for solving the problem lies either with governments or with experts or with health practitioners, and the answer is no. It lies, of course, with all of us, and especially with those at risk. I sometimes get the feeling that people think, oh, the elderly, they don't know, they can't take care of themselves, we have to take care of them. And therefore we do all the things that actually they should be doing. I think that's wrong, right? Again, if someone has dementia or, that's a special case, but usually, adult people are adult people and we have to treat them as adults, and those people at risk need to, first of all, be the ones who protect themselves. And if they can't do it by themselves, then their closest relatives have to look after them, right? But it is a responsibility of the individual, and not primarily the responsibility of some kind of conglomerate, government, or all the experts say this and that. No, we all have to think ourselves. It's not because someone is an expert doesn't mean they can think better than any one of us can, right? Expertise just means they know a certain area well. It doesn't mean they're good at thinking across the problem. Okay, outlook. I had this before, so I go through it very quickly. How about the vaccine? As I said, several scenarios. Let's first of all assume vaccine do become available early next year. Then one thing that could happen is if governments collectively decided to administer vaccines in a very systematic way to those at risk, we could conceivably, with a bit of luck, be through having vaccinated, let's say, 25 or 30% of the global population by July. And then we would really be, and if people recognize that that's what is needed to get through this, we would be in early spring by July. That's sort of the most optimistic scenario. Second scenario is if many governments around the world insist that the vaccine is not aimed just at the at-risk people, but it's aimed at everybody, and everybody needs to be vaccinated, or at least, let's say, 70 or 80%. So, herd immunity needs to be created with the help of the vaccine, even in countries where maybe already 40, 50, 60% of the population had already been infected. But you don't always know who it is who had been infected. Therefore, everybody will have to be reinfected again with the vaccine. If countries insist on, vaccinating entire populations, then next July we'll still be exactly in the same fractured world as today. We have not moved anywhere yet because it will take many, many months to vaccinate entire populations. Some countries will be quicker, they're richer, they're easier, it's logistically easier, whatever. But if many countries decide we will not go back to normal until we vaccinated either all or at least a big majority of our population, then next July we'll have not moved anywhere. We'll still be exactly in the same scenario that we're in now. The third scenario is even worse. we might even get deeper into the fractured world thanks to the vaccine. Why? Because what I said earlier, some countries are more dependent on the vaccine than others, and also within countries, obviously some people are more dependent on the vaccine than others, namely the at-risk people. So either between countries or within civil societies, there could be conflicts coming up because of the vaccine, distribution battles, who gets the vaccine first, right? All kinds of ugly things. If people are so hung up on this vaccine, and if the governments tell them, only when we have the vaccine, then everything, then you can travel again, then you can do this and that again, then you don't have to wear the mask again. If government make all of that conditional on the vaccine coming, and someone first having to be vaccinated before these normal freedoms are being reinstalled for them, then you can imagine everybody will be rushing to the gate to get the vaccine first, right? And all kinds of ugly things could happen. And then there's, of course, sort of a fourth scenario where we assume, let's assume for a moment, the vaccine remains elusive. And there is no vaccine next spring, or next summer, or next autumn, or next winter, right? Now then, we could potentially still get into the worst of all worlds, which we had called the abyss. Why? Because a prolonged wait for the vaccine, if it precipitates this viral diversification and this rise in infection fatality rates that I talked about earlier. So remember, viral diversification, if countries remain locked up, with borders closed, we may have a proliferation of the different types of the virus, right? Some of which could potentially be more harmful than the original. It's possible, not very likely, but possible. And here's the other point I should make. The longer someone like me who's 55 is prevented from exposing himself to the virus or the vaccine, let's say there's no vaccine, so I'm prevented by government, fiat, from exposing myself to the virus, because every day I'm getting, my immune system gets, a little bit weaker, incrementally, of course, but with every day I wait, my immune system potentially moves more towards that state of affairs where it is no longer able to fend off the virus by itself. So my risk, my individual risk of getting severely ill and dying goes up incrementally every day that I'm waiting and not able to expose myself to the virus. In other words, the sooner I get it, the better, all other things being equal, right? Governments will say, yeah, but when the vaccine comes, then you will see we did the right thing, because once the vaccine, then you're safe, right? But if the vaccine doesn't come, and governments still insist on keeping everything under control for months and months and maybe years, the IFR of this virus, instead of trending down, which is what we're expecting, could trend up again. Yeah. So the infection fatality ratio could eventually increase because of government policy, right? Just because they're holding out for the vaccine, and the vaccine remains elusive, and they're not willing to, just let go. And they continue to control the circulation of the virus, and therefore people, especially like at my age, they can't expose themselves to the virus, and slowly but surely move up into the ever higher risk, age brackets. Yeah. So in the very long run, and probably we're talking years rather than months, but maybe a few years, government policy, if the vaccine doesn't come, could still move us into the worst of the possible worlds, where the severity of COVID increases again. Preliminary conclusion: within a couple of years, the problem would naturally have resolved itself. It's just a common cold coronavirus, but policymakers are delaying this process and maybe making matters worse. In the short term, we could address the problem simply by shifting the focus from disrupting the chain of transmission towards disrupting the chain of progression in the at-risk people. So just focus on the at-risk people. But policymakers have staked their credibility on disrupting the chain of transmission, and may insist even on using the vaccine for that purpose. And then we are in that second or third scenario that I just talked about, where we are no better off in 6 months or 7 months' time or 8 months' time than we are now. So, in principle, early spring could be reached in a matter of actually weeks if we just started to send out the surgical mask to those people at risk. And yeah, it takes a few weeks, maybe months to get it to all of those people, get the supply chains working and all that. But we could be in early spring in very short, maybe not by the winter is at its peak, to be honest, in the Northern Hemisphere, but by the beginning of the spring in 2021, we could be in the early spring scenario. It's up to us. It's in our hands. But it seems that governments around the world have somehow conspired to linger on in the fractured world, either by default or because they actually like it there. So, some of you may remember this, this wallpaper here. No, we are not inside the matrix. I'm not suggesting we are in some kind of an artificial virtual reality world, but we are sort of in a Hollywood disaster movie, it seems. At least it feels like it. There's this tsunami rolling over us. And the tsunami, mind you, is not the virus, it's government policy tsunami. And whose director, I mean, the director of this disaster movie we seem to find ourselves in, is ourselves. We are creating and maintaining this crisis and this, what looks at the moment almost like a permanent state of exception. And with that, I thank you and wish you all the best and hope to see you again. Bye-bye.